So let's talk about different types of transfusions we can give to patients. So packed red blood cells, these are isolated red blood cells from the rest of the plasma. And why would we give it? We give it if patients' hemoglobins are too low. And hemoglobin is basically we use it as a surrogate for the amount of red blood cells we have. Remember, red blood cells have hemoglobin, so we look at hemoglobin levels. If it gets too low, we give more red blood cells. Now platelets, just again, it's isolated platelets from the plasma. And why would we give it? Well, you give it in patients who are bleeding from disorders of primary hemostasis, or if the patient's blood platelets are just way too low and you're worried that they're going to start bleeding because they've impaired primary hemostasis. Fresh frozen plasma. So fresh, it's basically just isolated plasma. You isolate the plasma, you take out the red blood cells, take out the platelets, you freeze it up, so you have fresh frozen plasma. So this plasma has all the clotting factors that were in the plasma, so all the clotting factors you need for secondary hemostasis. So why would you give it? Obviously, then you give it to stop bleeding that results from disorders of secondary hemostasis, or you can also do it to reverse anticoagulation. So if, for example, something like if you give heparin, you give warfarin, especially warfarin's a big one. Remember, what do we say with warfarin? The mechanism of action, remember, it blocks vitamin K reduction, so now you don't get activation of clotting factors. So one way you could do for warfarin is you can give more vitamin K, and that can help reverse warfarin anticoagulation, but that takes some time. So if you want faster, if you have a patient that's bleeding, you don't have time to get them vitamin K, it takes almost like hours to days for that to get reversed. You just give them clotting factors. Remember, the problem in warfarin is that you don't have active clotting factors anymore, so you just give them some active clotting factors in the plasma, and then you fix the problem. So next is prothrombin complex concentrate, it's PCC. It's basically a more concentrated version of fresh frozen plasma. So you basically concentrate up these clotting factors. You have a lot more clotting factors per volume. And so you give it for the same reasons you give fresh frozen plasma, except it just works better. You can do it, and you get hemostasis more quickly. Finally, Cryo Precipitate. This stuff is the insoluble material that comes out of solution when frozen plasma is thawed. And this stuff, it's okay, so you thaw this fresh frozen plasma slowly, so at a specific temperature, the stuff that dissolves out, that melts out, is this Cryo Precipitate. Okay, and especially rich in fibrinogen. So you give it in bleeding in which there's decreased fibrinogen. For example, remember I mentioned one, which was DIC, where DIC had decreased fibrinogen as well as increased D-dimers. It's all just due to consumption, and then D-dimer was from too much fibrin cross-linking and breakdown of all that fibrin cross-linking that you get. So next topic is transfusion reactions from red blood cells. So adverse reactions from red blood cell transfusions. So there's going to be a lot of things that you can get from giving someone red blood cells. Actually, they don't happen too much, but you can get them. So anaphylactic reactions. So this is immediate. This happens is the type 1 hypersensitivity. You see in IgA deficient individuals receiving blood with IgA antibodies. So if they're deficient, IgA, yeah. If they're deficient, they're going to start developing antibodies against these IgA antibodies, because they might just get exposed to IgA sometime or another. And you give them a whole packing bunch of blood with IgA antibodies against it, IgA antibodies, their antibodies are going to go crazy. You're going to get a type 1 hypersensitivity. You're going to get anaphylaxis. And what were the symptoms of anaphylaxis? I mean, you can get a lot of things, but especially like wheezing, hypotension. It's a severe allergic reaction. You get respiratory arrest, you're going to get shock. It's going to be a lot of problems. It's shock from that vasodilation. So anaphylactic reaction. Next is allergic reaction, minutes to hours after transfusion. Similar thing, except for it's against donor plasma proteins. Type 1 hypersensitivity against donor plasma proteins. So just proteins floating around in that blood that you give to the patient. You can get allergic reactions. So you can get things like hives or itching. Next is acute hemolytic transfusion reaction. This is within 24 hours. This is a type 2 hypersensitivity, and it's due to ABO incompatibility. So remember, I told you about this. We get exposed to the bacteria antigens. You make antibodies against antigens that you don't have yourself, and if you give a patient red blood cells that have the antigen that you have antibodies against, then those antibodies are going to destroy those donor red blood cells. You get a hemolytic, and you get hemolysis, you get fever. Okay, so that's the findings you're going to get. What were the hemolysis findings? Remember, hemolysis leads to increased bilirubin. So you can get jaundice, you can get itching, and things like that. You can get anemia, okay, just low red blood cell count from destruction. Next is delayed hemolytic transfusion reactants. Delayed, so it's 1 to 14 days after the transfusion. And this is type 2 hypersensitivity, but it's against the donor antigen in the red blood cells that the patient was previously exposed to. Okay. You get the same thing as you get fever, you get hemolysis. It's just a little bit later. It happens a little bit later. Next one is febrile non hemolytic. So it's not a hemolysis reaction. What happens is you have cytokines in the donor red blood cells. Donor leukocytes make these cytokines. You put it in the patient. These cytokines go around the body, go to the brain, and they cause fever. Okay. So that's the clinical feature here. You get fever in a febrile non-hemolytic transfusion reaction. Finally, we have transfusion-related acute lung injury. We often abbreviate into TRALI. Transfusion-related acute lung injury happens within 6 hours of transfusion, and we don't know exactly why, but there's a hypothesis. So you have a problem that causes neutrophil sequestration in the lungs. They get primed, so they're ready for action. And this happens due to endothelial injuries. Endothelial injury leads to neutrophil sequestration and priming in the lungs. And then you give the patient blood product, and there's a factor in the blood product that activates these neutrophils. Neutrophils cause inflammation, damage to the lung. You get injury, you get transfusion-related acute lung injury. And the symptoms then will be from the lung injury, you get pulmonary respiratory distress, you get pulmonary edema. So, I recommend you paying attention to the names. Anaphylactic then makes sense. You get anaphylaxis symptoms. Then just the IgA for anaphylactic. Allergic is hypersensitivity against donor plasma proteins. Symptoms are allergic symptoms. And then the hemolytic ones are from type 2 hypersensitivity. Acute would be hypersensitivity to the ABO, and then the delayed would be to a donor antigen. And then you get the similar findings. You get that fever, you get that hemolysis. Okay? And then finally, febrile non-hemolytic then would be, it's not hemolytic, so how do you get fevers? It's because you have these cytokines from the donor. It has to be the donor. You can't have cytokines in the patient itself, or else they already have a fever. But it has to be in the donor. Cytokines from the donor leukocytes, and once you put in the patient, they go around and they basically cause a fever in the patient. And then finally, transfusion-related acute lung injury from that two-hit hypothesis, endothelial injury with neutrophil sequestration, and then activation by a factor in the blood product. You get damage to the lungs, you get respiratory distress, pulmonary edema. So that's it for red blood cell transfusion reactions and why we do different transfusions.